Good morning, everybody. My name is Stuart Sweet. I'm a pediatric pulmonologist from Washington University in St. Louis. And this is my co-chair, Harmit Grossman from Sick Kids at Toronto. And we're delighted to see all of you here for our workshop session entitled Lung Transplant Recipients. This is Lung Transplant and Pulmonary Vascular Biology. And our first talk is going to be given by Dave Young from the University of Washington. Dave is an undergraduate student who works with Kathy Ramos, and he's double majoring in molecular, cellular, and developmental biology and psychology with a minor in global health. And he's going to speak to us today on a talk entitled Lung Transplant Recipients with Cystic Fibrosis, Perspectives on the Use of Elexacaftor, Tezacaftor, Ivacaftor. Dave, come on up. You're going to sit in the front.
Just start when the timer starts.
There you go.
All right. Hello and good morning. Thank you all very much for being here and for being interested in my talk. My name is Dave Young. I'm an undergraduate student at the University of Washington, and I'm working with Dr. Kathy Ramos. Before I begin, I'd like to take the time and thank the session chairs for inviting me to speak here today, as well as for moderating the session. It's truly an honor to be here with all of you at NACFC 2023. Today I'll be discussing perspectives on ETI among lung transplant recipients with cystic fibrosis. And all the results I'll be describing today have recently been accepted to the Journal of Cystic Fibrosis if you're interested in learning more about it after the talk. Oh, slide's not working. Oops. All right. And I have no relationships to disclose related to this presentation. So post-lung transplant, people with cystic fibrosis face a wide range of extrapulmonary complications, including diabetes, GI symptoms, and sinus symptoms, all of which are symptomatically burdensome and can lead to lung inflammation or infection on their newly transplanted lungs. The usage of ETI post-lung transplant could potentially alleviate these symptoms. However, there's been very little research on its impact and risks and benefits on this population. In addition, it is rarely prescribed. In fact, prescription rates vary significantly across transplant centers in the United States. Given this lack of research and the importance of ETI that it could hold for this population, we advocate for further research on the impact of ETI for lung transplant recipients with cystic fibrosis. And to further inform this research, in this study, we sought to understand awareness and attitudes toward ETI among lung transplant recipients with CF. And to answer this question, we distributed a cross-sectional survey across the entire lung transplant recipient with cystic fibrosis population here at the University of Washington. We conducted the study over a period of 6 months from October 2022 to March 2023. And our inclusion criteria is simply being a lung transplant recipient with cystic fibrosis. We did not have any exclusion criteria and included everyone regardless of prior use of ETI or eligibility for ETI. In addition, our survey measures that we used included Likert scale questions, open-ended responses, and short responses. And clinical data was extracted from the EHR when it was not self-reported in the survey. And we used descriptive statistics to summarize patient characteristics. So this figure right here is a concert diagram describing our participant recruitment pathway. In total, we identified 81 lung transplant recipients with CF at the University of Washington. Out of these 81, we were successfully able to contact and invite 58 or 72% of them to fill out our survey online. And then out of these 58, we received 46 complete responses, which came out to be about an 80% response rate, which was very good. So this table describes the demographic and clinical characteristics of our participant sample. We have our respondents on the left with a sample of 46 and non-respondents with 35. The median age of our respondents was 42 years old. They were 60% female, and they were generally older population. Their median year of first lung transplant was 2014. And based on their FEV1 and FVC values, they were a generally healthy population with good lung function. About 2/3 of them were privately insured, a third were on Medicaid, and half of them had 2 copies of the F508del CFTR mutation. And when we compared respondents and non-respondents, we did not find any significant differences with a p-value greater than 0.05. The first question we wanted to ask in the study was, what non-pulmonary comorbidities are present in patients post-transplant? And here's what we found. Lung transplant recipients with CF have a wide range of non-pulmonary comorbidities. And out of these, we found several significant findings. The first of which was diabetes, where over 80% of our sample had these comorbidities. Nearly 80% had sinus symptoms, and 72% had prior sinus surgery. 60% had osteoporosis, nearly half reported having a mental health issue, and a quarter had cancer history. So clearly there's a lot of non-pulmonary comorbidities that are present in this population, and we believe that these participants may be drawn to ETI due to the potential benefits that it may hold for these non-pulmonary manifestations of their CF. Importantly, 100%, every single one of our participants had at least one comorbidity. Our next question was, are participants aware of ETI? And what we found is that 90% were aware of ETI prior to taking the survey. And then we also asked about the various means by which they had heard about the survey. 3/4 of them had heard of it through either the cystic fibrosis or transplant clinic, another third through social media, another third through word of mouth, and about 28% had heard of it through either a written or online newsletter. About 20% had heard of it through web search. But out of these that had known about ETI, how many had actually taken ETI? We found that 11 or 24% of our sample had taken ETI as part of their treatment course. And out of these 11, 5 of them had taken it only before transplant, and 6 of them had taken it only after transplant. Interestingly, none of them had taken it both before and after transplant. We next wanted to know what are participants' actual perspectives on taking ETI post-transplant. And we answered this question using 2 methods, the first of which was Likert scale questions, which I'll describe on the next slide, and then open-ended responses, where participants were given the opportunity to provide their own personal opinions on ETI post-transplant. So for perspectives on ETI, the first question that we asked participants was, how important is it to you to treat non-pulmonary symptoms caused by your CF? What we found is that 98% of our participants reported feeling at least somewhat or very important to treat these non-pulmonary symptoms. We next asked, would you be comfortable taking ETI given what you currently know about the medication? And what we found is that 70% reported being at least somewhat or very comfortable taking ETI at the time of the survey, given their current knowledge. Our last question was, are you interested in learning more about the use of ETI post-lung transplant? What we found is that 88% reported feeling it or at least somewhat or very interested in the use of ETI post-transplant. But given this interest in ETI, we also wanted to know about the concerns that recipients had about it. Out of these, 3/4 of them were worried about possible drug interactions with their transplant medications. Half were concerned about side effects. Another half about the cost of the medication. 44% were worried that there was absolutely no clinical data at all for people with transplant. About 1/4 were worried that there was about weight gain, and about 20% were already doing well and didn't feel the need to add a new medication to their already long list. And about 10% thought that there would be no benefit to their newly transplanted lungs. And now on to the open-ended responses. So the specific survey question that we asked to participants was if there's anything else you would like to mention to the researchers about your opinions taking Trikafta after lung transplant, please mention them here. And so once we received the responses, we categorized them based on the relevant issues that were brought up in each response. And what we found is that 47%, or half of all open-ended responses, mentioned sinus issues, and other themes, which I'll go over quotes on later, included diabetes control, expenses, side effects, and cost of medication. All of those concerns that were brought up previously. And the first quote that we have for sinus issues was, I am particularly interested in sinus benefits. I have continuous sinus infections, and secretions invariably make it into my lungs, causing a constant cough. Next, a participant said, I was hoping it would help my sinuses since they can cause infection in my new lungs, but the side effect was too much to keep trying it. Another exemplary quote we had for diabetes control was, I would be interested because of the chronic sinus issues I managed and the possibility of improved control over my diabetes. And the last quote we have is for expenses. One participant said, my biggest concern is taking another very expensive medication and becoming dependent on it, only to have to fight my insurance for it. So that summarizes the results of the study. The limitations of the study are obviously that we only conducted the study at the University of Washington. Although it's a large lung transplant program, perspectives on ATI could vary across other centers. In addition, our participant pool was primarily white and relatively highly educated. This limits the generalizability to the overall lung transplant recipient population with CF. Further, participants that were unaware of ATI at the time of the survey may have been less likely to respond, potentially biasing our study results. So the take-home points from this study are that overall, lung transplant recipients with CF are highly, highly interested in ATI post-transplant, particularly for their non-pulmonary manifestations of their CF. This includes sinus issues, gastrointestinal symptoms, and diabetes, among many others. Despite this interest, there are many concerns about the potential risks and the lack of clinical trial data. Overall, this indicates that there still needs to be a lot more research that needs to be done before we can confidently make a recommendation about the use of ATI post-lung transplant. And finally, lung transplant recipients with cystic fibrosis look to their clinicians for communication and shared decision-making about novel cystic fibrosis therapeutics. The future directions for this research that we recommend are to first assess clinician uncertainty about ETI post-transplant, investigate further the pharmacokinetics of ETI in combination with transplant medications, gain other patient perspectives from other centers, not just the University of Washington, and lastly, we really need real prospective clinical trial data assessing the efficacy of ETI post-transplant. Well, that's everything I have. I'd like to acknowledge the people with cystic fibrosis that participated in our survey and overall contributed to the research in general, and also finally the entire research team who helped with the study and made it possible. And with that, I'm happy to take questions.
Well, thanks very much. Not sure you guys can hear me from this microphone, but for a great talk and a great study. There's two ways that you can enter questions. There's a way on your app, but also it's easier. There's a microphone right in front of you. I guess I'll start with one question. It may be a little hard, but the context of ETI after a lung transplant is one potential post-transplant intervention with ETI. I'm curious, ETI after a liver transplant or before liver transplant is another possibility that you might study to get a little bit different perspective on the patient's interest in using it. Now, in a liver transplant, obviously the lungs are still potentially an issue. So my guess is the pulmonologists are going to be pushing ETI in patients who qualify. But I'm curious whether you'd thought about that as a potential.
That's a great question. Honestly, I don't really know. We didn't think about liver transplant and the possibility of ETI being a treatment for it. But my mentor, Dr. Ramos, probably has an answer. I see her coming up right now. So, she's going right there. Yep. She knows a lot more than I do.
You did an excellent job. Great job with the talk. So the issue is that they still have pulmonary disease from their CF after a liver transplant. So I think the risk benefit of the drug interactions after a liver transplant is clearly in favor of giving the Trikafta, giving the ETI. At least that's been the experience I've heard in the community, is there's a lot less controversy after a liver transplant.
Go ahead, Erin.
Hi, Erin Lowry from University of Wisconsin. Great talk. I'm wondering if you can tell me a little bit more about the approach at your center in terms of telling the patients about ETI. Is it all CF patients after transplant are educated about it, or is it just select patients who have certain complications, or?
Mm-hmm. Yeah, that's a great question. I think Kathy might also be able to add to that a little bit, but the policy at the University of Washington post-transplant is to discontinue ETI for all patients and only recontinue on a case-by-case basis. And so the education for patients on ETI post-transplant would be done on a case-by-case basis. And our survey results show that only 90% of them were aware of ETI out of all the recipients with CF followed at the University of Washington. And so there clearly are some people who fall through the cracks and are educated about it. Kathy, if you have anything else to add, feel free to.
Yeah, I think people who have non-pulmonary manifestations of CF are more likely to have that conversation. So if they have sinus disease that's really symptomatic, we're more likely to bring it up. But I think on their slide where people heard about ETI, 75% of the people who responded to the survey said it was in CF or transplant clinics. So we clearly were talking to these people about ETI, but the people who didn't respond to the survey, maybe they haven't heard about it. And we don't have a systematic approach to all the patients right now.
Go ahead, Lauren.
Hi, I'm Christina Mangora from Medical University of South Carolina. So we have a similar practice where it's either brought up in transplant or CF clinic and it's case by case. But I was just wondering if you, in getting your survey, had collected any specific complications or adverse effects events that happened in the post-transplant population that led to discontinuation.
So you're talking about the 6 people who were not on ETI post-transplant?
Yeah.
Okay. We didn't look into that specifically. That would probably have to be done, in the that's a great question. Probably in the EHR separately. But I think it's just a policy that we have as a baseline. Everyone is discontinuing ETI, and then from there, that's where we start in considering whether they should be taken on or not.
And I guess my other just kind of part with that is, do y'all, and Kathy may have more insight into this, but do y'all use modified dosing on a regular basis or only based on azoles and other known DDIs?
I'll answer the second question first. The drug interactions are usually the reason that we're changing the dose, and it's very experimental to change the dose of ETI based on side effects and titrating it to concentrations or sweat chloride or other. So we're not doing that regularly. And then the first question about the reasons for discontinuation in our patients, there were 2 that we just briefly quickly talked about. One, it was severe constipation, and the other person was wheezing. And we published the experience from the CF Lung Transplant Consortium in JCF last year, and there were a few people who stopped ETI because of shortness of breath or wheezing or something along those lines, but that was 94 people, of whom 40% stopped, and we had a list of the reasons why they stopped.
Do you know whether insurance coverage is an issue for this population compared to the pre-transplant population, or just the fact that they have a diagnosis of CF gets it taken care of?
Almost 0%. At our center, it's 0%.
Yeah.
But in the entire consortium, just 1%. No, it was private insurance. Yeah.
No other questions? Thanks again for a great talk.
Thank you very much.
Congratulations. Just get the...
All right, so that was a great start for the session. Thanks, Dave. That was very nicely presented. So the next speaker is Aniket Sidai. I hope I pronounced that properly. And his talk is on psoas muscle area, maybe a useful measure to predict fracture risk in people with CF and a transplant. And you have 15 minutes to entertain us.
Okay, thank you to the workshop organizers for inviting me to present our work to you today. I just want to highlight that a lot of this work has been done by Bahram Muhajir, who was a very talented postdoc in radiology. He's going to be doing a radiology residency at the University of Pennsylvania next year. So for those of you from Philadelphia, take note. I'm a faculty member at Hopkins in Baltimore, and I'm happy to be talking to you today. So I don't have any relevant disclosures. Here's a brief outline of my talk. Essentially, we're interested in identifying radiologic biomarkers that can help improve risk stratification for fracture after lung transplant. I think this audience knows very well, Dave just highlighted that persons with CF have a high prevalence of low bone mass. CF-related bone disease is a multifactorial disease. And the problem with low bone mass is that it is a risk factor for fracture. Indeed, in persons with CF awaiting lung transplant, there is a high prevalence of fractures. And in studies that look at both morphometrically identified fractures as well as clinical fractures, that prevalence may be as high as 45%. After transplant, there's also a high incidence of fractures. And the picture on the right is simply meant to show you a fracture at, in this case, the T12 vertebra and the deformities that can ensue. And so fractures are associated with a high degree of morbidity, a risk for future fractures. And you can imagine that somebody with multiple rib fractures and vertebral fractures, that this may compromise graft function. So there is certainly a need to have good risk prediction for fractures. Dual energy X-ray absorptiometry, or DEXA scan, is the gold standard to assess bone mineral density. And the picture on the right simply shows a DEXA scan image and how, for example, lumbar vertebrae might be traced and the density might be estimated. DEXA scans calculate a two-dimensional bone density expressed in grams per centimeter squared, or an areal bone density. An individual's areal bone density is compared to a reference population to obtain a T-score or a Z-score. That would be a reference population that is young and gender matched, or same age and gender matched, respectively. The most well-established use for this is in postmenopausal women, where, as many of you know, a T-score of less than -2.5 is called osteoporosis and warrants a discussion about pharmacologic treatment. And so we have guidelines to help guide us about who should get treatment. The European CF guidelines from 2011 answer the question when to use pharmacologic agents in lung transplant candidates or recipients. And if the bone mineral density Z-score is less than or equal to -1.5, this should prompt a discussion because these patients would be considered at high risk. So what is a typical treatment? Correction of vitamin D and calcium deficits is an absolute must as part of the treatment protocol. But in terms of pharmacologic management, there are a variety of medications available, but bisphosphonates are the most commonly used medications. And on the right is a diagram just showing you how bisphosphonates work. Nitrogen-containing bisphosphonates are taken up by osteoclasts. These are the cells that resorb bone or chew up bone. They inhibit osteoclast function and induced osteoclast apoptosis. This shifts the balance of bone resorption and bone formation to favor bone formation, which is conducted by osteoblasts that are not affected by bisphosphonates. And bisphosphonates work to improve bone mineral density. To my knowledge, there's only one randomized controlled trial that was published about 20 years ago now, looking at intravenous bisphosphonates compared to a control group. And bisphosphonates induced an 8% increase in bone mineral density. But there remain some issues regarding clinical management, and studies regarding the association between DEXA-derived areal bone mineral density and the risk of fracture in persons with CF undergoing lung transplant are mixed. That is to say, when looking at patients who have fracture versus those who do not, the areal bone mineral densities or the Z-scores do not statistically differ in some studies. In one particular study published recently, they do. Whether the use of bisphosphonates is associated with reduced rates of fracture in persons with CF is unclear. Most of the studies are not really powered to demonstrate this effect, but in general, most studies show that comparing people who receive bisphosphonates to those who don't, the rates of fracture are not that different. So, essentially, our existing fracture risk assessment tools have limitations in persons with CF, and the benefit of commonly used treatments is not established with regards to fracture prevention. And I'm careful to say fracture prevention here because bisphosphonates most certainly increase bone mineral density, and increased bone mineral density has in certain clinical contexts shown to be associated with a reduced fracture, but demonstration of reduced fracture risk has not been really done. So we need improved fracture risk stratification, and we were curious to know whether existing studies contain data that could help inform about risk. To put it more simply, we know that patients undergoing lung transplant get a lot of studies, CT scans in particular, And we wanted to know whether there was untapped information there that could be A, harnessed, and B, used. So we were interested in two measures, volumetric bone mineral density and psoas muscle area measurements. So volumetric bone mineral density is exactly what it sounds like. So you can see three different sections here, a coronal, sagittal, and a cross section, where regions of interest can be drawn, and a volumetric bone density expressed in milligrams per centimeter cubed can be calculated. Theoretically, volumetric bone density captures cortical and trabecular bone mineral density better than areal bone mineral density. There are studies that suggest that volumetric bone mineral density predicts vertebral fracture risk better than just areal bone mineral density. This is in a non-transplant, non-CF population, and this has not really been investigated in a transplant population as yet. The other thing we were interested in was psoas muscle area. Psoas muscle area, shown in the filled up psoas muscle area in orange, allows one to estimate whether there's sarcopenia present. Sarcopenia is a component of the frailty syndrome, which in the aged population is associated with functional and physical decline, increased morbidity, and mortality. In surgical series, sarcopenia has been associated with poor perioperative outcomes in certain studies. And in the lung transplant population, a group at Hopkins has investigated sarcopenia of the psoas muscle and found that it is associated with increased mortality after transplant, reduced lung function, and graft dysfunction. CF patients in specific have not been studied with regards to sarcopenia of the psoas muscle. So we proposed a pilot and feasibility study to conduct a retrospective analysis on previously collected data from CF patients who had a lung transplant between 2009 and 2019. Their computed tomography data was extracted. We collected other parameters as well. And volumetric bone mineral density at T11 and through L1 vertebrae was measured using Mindways QCT Pro software. I just want to mention that this software is not FDA approved for use for calculation of VBMD without a phantom, that is to say, a block that things can be calibrated against. And we conducted phantomless scans. Rather, we use a software without phantoms. Psoas muscle area, which was a sum of the left and right psoas muscle areas, was measured at the L4 transverse level using 3D slicer software. And essentially, we wanted to see if these parameters, volumetric bone density, areal bone density, and psoas muscle area were correlated. And an exploratory question was, are there differences in these parameters in patients who have fractures versus those who do not? So this is the timing of our study assessments. Hopefully you can see. We considered three different time windows. We considered pre-transplant to be 6 months prior to 2 years prior to transplant. The peri-transplant time window as being 2 months prior to 2 months after, and the post-transplant window to being 6 months to 24 months after. Psoas muscle area was calculated in the pre-transplant window, and DEXA scans or areal bone mineral density was obtained from pre- and post-transplant windows. But volumetric bone density, just because of the nature of when CT scans are obtained in the course of transplant evaluation, were obtained in all three windows. And part of this pilot and feasibility study was really to see, well, are there scans that can be looked at? What are those number of scans? Do they match up? Are they comparable? And so here are some of our results. We had 59 patients who had a transplant between 2009 and 2019, and 32 were excluded. The most common reason for exclusion was that 16 did not have an appropriate CT scan. Usually this was related to intravenous contrast administration, but there were other factors as well. Of the remaining 27 patients, 26 patients did have a CT and a DEXA scan pre-transplant, and 21 patients had a post-transplant CT and DEXA scan. But there were 16 patients who had both pre- and post-transplant DEXA scans to make for longitudinal assessments of changes in bone mineral density. In the interest of time, I'm not going to go over the demographic information in detail, except to say that our patients look similar to other transplant patients in terms of their age, the prevalence of diabetes. At least on average, there was not substantial hyperglycemia present. And I'll draw your attention to the bottom, my left side, but your right side corner. that shows that the time interval between VBMD pre and post-transplant was similar to the time interval between DEXA pre and post-transplant. But hopefully what you can see is that there was quite a lot of variability in the timing of the DEXA scans. So our results showed that pre-transplant VBMD correlated with pre-transplant aerial BMD in the areas that we typically look at, spine, femoral neck, and total hep. And post-transplant VBMD correlated with post-transplant ABMD as well. However, the change in BMD when normalized by time interval between the scans did not correlate between spinal aerial bone mineral density and volumetric bone mineral density. What about fracture? This is a preliminary analysis. I'm sorry, the numbers are not here, but they're in the low teens for each group that had an incident fracture and no fracture. And we saw that the average volumetric bone density in those with incident fracture was lower at all time segments, pre, peri, and post. These differences were not statistically significant. Qualitatively, when we looked at the data, we noticed that there were different patterns of volumetric bone mineral density lost. So on the right-hand side is volumetric bone mineral density on the y-axis, and on the x-axis is simply these three different time windows, pre, peri, and post-transplant. And there was a group that had stable bone mineral density throughout the three time windows. That's shown in green. And another group, shown in red, had progressive decline at every single time window. And there was a group that declined initially and had stability of bone mineral density afterwards. And in comparing the progressive decline group to those who had stable bone mineral density, they were older, had a higher incidence of post-lung transplant fracture, but the pre-transplant DEXA-derived Z-scores were similar between those two groups. Obviously, these are very small numbers, and I can't comment on whether this was statistically significant or not. What about psoas muscle area? We were able to obtain psoas muscle area measurements in 21 subjects who had eligible scans, as well as DEXA scans, and 8 of those had a fracture post-transplant. In this group, the BMD Z-scores did not differ between those who did or did not have a fracture after transplant. And the psoas muscle area did not correlate with aerial BMD nor with VBMD measurements. Perhaps that's not surprising, given that this is measuring something completely different. When looking at those who had an incident fracture post-transplant, who were 8 in number, versus those who did not have a fracture, who were 13, we saw that the ages were relatively well matched. There was 1 male in the group that had incident fracture post-transplant, and 6 in those who did not have fracture. The psoas muscle area was lower in those who had incident fracture post-transplant and those who did not, versus those who did not have a fracture. I'll just note that in the study that looked at psoas muscle area in transplant patients that was done by our group, they defined sarcopenia using cutoffs. And the cutoff for women was a psoas muscle area less than 6.4, and they defined sarcopenia in men as a psoas muscle area less than 8. So what are some of our conclusions? Our pilot study suggests that collecting VBMD and PMA opportunistically from existing CT scans is feasible. That longitudinal changes in VBMD do not correlate to longitudinal changes in ABMD. That there may be different patterns of VBMD change and lower psoas muscle area pre-lung transplant may be associated with a higher incident fracture rate. We believe that studies involving larger numbers of patients may allow better phenotyping of these different patterns of VBMD change and correlation of these parameters to the risk of fracture and other adverse lung transplant outcomes, and may eventually allow for improved risk stratification post-transplant. Our study has several limitations. It is single center and retrospective. The number of patients were small, and a lot of this was due to either missed scans, meaning they just didn't get their DEXA scan, for example, scanner incompatibility, or in the case of the CT scans, whether the energy characteristics of the scan that were done were something that could be used for volumetric bone mineral density. I've written lack of appropriate control group. I think lack of appropriate comparison group would be a better word here. And we did not obtain pre-lung transplant glucocorticoid exposure, and other studies have shown that this does correlate to incident fracture risk. I'd like to acknowledge that this work was supported by the Pilot and Feasibility Award from the Cystic Fibrosis Foundation. These are my references, which I'm sure you cannot read, and I'm happy to take your questions or comments.
Well, while people are coming up to the podium to ask questions, I have one. In the patients that had the progressive decline, and maybe I missed this, but did you notice whether there was any differences in treatment? Did they have more rejection episodes? Did they get pulse steroids? Was there any risk factors that you identified in your analysis for the rapid decline?
That's a great question. There were obviously not so many patients overall in that group. It did appear that they did have more steroid exposure. It wasn't statistically significant compared to the other groups, so that was one factor.
Can I just quickly ask another question, but my mic isn't working, so I'm going to borrow this. So, can you educate me on psoas muscle mass a little bit? Do you think it's reflective of like general physical strength, or does it correlate with other muscle mass, or do you think it is?
Yes, I think it is simply a measure of sarcopenia, whether there has been a reduction in muscle mass that has occurred. This is something that happens commonly in people who, as they age. And if there's more sarcopenia, there are more adverse outcomes. But you could look at sarcopenia in different muscle groups. I think this happens to be one that is more easily obtained from CT scans.
And is there any data suggesting that the psoas muscle mass can be trained, like in exercise programs, for example?
It's a good question. I'm not aware of studies that went and looked at what happened to the psoas muscle mass. I think, at least in the papers, it's just a state of decline that may exist. There are some studies that suggest that it's associated with a pro-inflammatory state, which may be a hypothesis of why those patients had poorer outcomes.
Okay, thank you.
I guess one more question since we have a little bit of time. Can you explain to me sort of why you would have gotten a non-contrast versus a contrast CT as a part of the pre-transplant workup? And could that difference between those two populations have biased what you were looking at?
Well, I'm an endocrinologist, so I don't order the CT scans.
And I'm a pulmonologist, so I try to avoid abdominal CT imaging, but I'm just curious if anybody could explain sort of why you would have gotten a non-contrast CT that allowed you to get the psoas muscle. And
I think that my understanding, and there's a whole bunch of lung transplant experts here, so you can correct me if I'm wrong, is that as part of the pre-transplant workup at our institution, a chest, abdomen, pelvis scan is routinely obtained with and without IV contrast. I don't know if that's part of the screening for malignancy, for example, that may preclude somebody from transplant consideration or at least put it on pause. But I'm happy to hear about other perspectives. But you're right. Like if they had a little bit of renal failure and that's why you didn't do the IV contrast, that could certainly bias things.
So it might have muddled your ability to connect that to a specific outcome.
Correct.
So Joe.
Hi, good morning. Joe Paluski from Pittsburgh. I've asked that same question, Stuart, on innumerable occasions. Why are we doing abdomen pelvis CT scans on 50-year-olds who have no evidence of vascular disease? And the explanation I get, just to share it, is they want to look at the vessels for cannulation. I'm not sure that's a good reason. And I think for malignancy screening, CT is probably a terrible test with no data to support it. But radiation, I guess that people are not too as sensitive perhaps as they should be to radiation exposure cumulatively.
Yeah,
sure.
It provides for a nice study material. So nicely done.
Thanks.
Well, thanks very much. Appreciate your efforts. Okay, we're going to switch gears now and move to pulmonary vascular biology. And our next speaker is Kiwei Xiao from the University of Cincinnati. He's a research associate there who has a focus on respiratory system modeling through computational fluid dynamics and has extensive experience in xenon imaging and machine learning applications in respiratory medicine. Kiwei.
Good morning, everyone. It's a great honor to be invited by the session chair to have the opportunity to give the talk here. So I'm like being introduced. My background is aerospace engineering, so I generate interest into bringing my fluid dynamics expertise in modeling human, respiratory system, such as fluids in airway and blood in the vessels. So today I'm going to talk about the pulmonary vascular disease in cystic fibrosis. So there are two objectives in this talk. So we want to evaluate the morphology of the pulmonary vasculature in the patients with CF who have a wide range of the lung functions, and as well as to determine the relationship between morphology, structure, and to the functional outcomes. So second aim would be trying to do the similar analysis, but evaluate the changes before and after 1 year Trikafta treatment. To achieve those two goals, we need a CT image of each subject, and we're going to apply the imaging-based quantifications will be introduced later. And then, to link with the functional outcomes, we need the pulmonary functional test result and cardiopulmonary exercise test result as well, and also the lung clearance index. So before getting metrics, we introduce the demographics we have in this study. So we have 164 CT images from the patients with cystic fibrosis from 2 medical sites. So 60 of them are prospective images. We also have 68 control subjects from the non-CF group. Those all the controls are retrospective images, for the subjects with normal trachea, lung, and heart disease, as indicated by the radiologist report. So 27 out of all the CF group, they had a pre and 1 year after Trikafta treatment images. So table here is just a brief summary of the age, BMI, FEV1, and gender ratios between control and CF group. So here we would like to introduce the imaging-based methods we used. So as you can see from the left, we basically take the CT image and then we do the segmentations using the algorithm. So we can segment the lung, and then we're gonna divide the lung into left and right accurately, and gonna apply this process side by side. So, and then we apply some denoising algorithm like here's the mouse. Yeah, the bottom. This one, we denoise the image, and then we increase the signal in the vessels, and then we get a prediction map of where the vessels are, and then we finally apply a lung contour mask to get rid of all the noise outside the lung. Eventually, we get a map on the right, and so this method is originally developed by the Dr. Esther from Harvard. So we work together to make this code work for the CF patients. So the red figure represents the whole vascular tree in the lungs, from the large vessel gradually to the as indicated by the red color, and to the smaller vessels as well, which is colored by blue. By having this map, we can really quantify the blood volumes in all different sizes of the vessels. But in this study, we really particular interest in the blood volume in the small vessels, because we know this pathology starts from peripheral vessels. The specific metrics we use is called BV5%. So what that means is it's a ratio between the blood in the smaller vessels, cross-sectional area less than 5 millimeters squared, over the total blood volume in this segmented vascular tree. So I'm gonna call that BV5% throughout the slides, as it essentially just means the fraction of small distal pulmonary vessels. The red figure here is a visual representation, just shows as this BV5 changed, what that means in terms of the vasculature in the lungs. From A to B is BV5% reduced from 66 to 58, and continues to 47, and very last is the 18. It's very extreme one. As you can see, we have a smaller BV5% indicates you are losing smaller vessels, which you only have the big vessels left in the lung. The functional metrics we used are, DLCO%, that is a diffusion capacity of the lungs. It measures, your lungs' ability to transfer the gas from inspired air to the bloodstream. Of course, just by the hemoglobin level, and also the VO2 max. That's the maximum oxygen consumption at the peak exercise, and this generally represents your fitness of your cardiovascular system. And lastly would be the LCI at both 5 and 2.5%. Simply saying it just measures the ventilation and humidity of your lung. If you have a higher value of LCI, just maybe indicates more underlying lung disease. So how we gonna evaluate this morphology with the functional outcomes? We can try to achieve that by answering those 3 questions. So the first one, we look at how does this morphology measurements, BV5%, related to the CF severity and age, and also we study the relationship between the morphology with all the function outcome measurements. Lastly, we carry out this same analysis, but between pre and 1 year after Trikafta treatment. So first, here we're looking at the relationship between BV5% with the FEV1% predicted. We can see there's a strong linear relationship between those two, and in more details, we can see the BV5 starts reducing as the patients have a pretty healthy lung functions, as indicated by FEV1%. And then we're curious, what about the we wonder when does the patient start losing the smaller vessels? So we fit a cubic line of the data. We're trying to indicate the point of inflection, which is at about 107 of FEV1%. So how about the relationship with age? So as you can see, it has a significant linear relationship. And also we can see the losing of declining of BV5% starts as early age, as in the data set, as all the data we have is start at age 7 and it continues declining with as the patient's age. So as I mentioned, we have the controls as well. So we look at what about the relationship in the controls. So here's the this is the result within control. So we cannot see such a obvious relationship in the control subjects. There's no such relationship in the control subject between the BV5% and the age. So how about the the relationship between the morphology and the functional functional measurements? So we first check the BV5 with the DL0%, as we can see is significantly correlated, as well as for with the VO2 max. Now we're gonna wondering how does the Trikafta affects all those measurements. So first we check the variations between pre and 1 year after Trikafta. We can see as as expected, we see the FEV1% predicted and VO2 max, they all significantly increased. As well as the lung clearance index reduced. However, we see a slight reduce of the DL0%. Well, as you can see, the changes is really minor, but it just shows statistically significant. So whether it's clinical, significant or not, I'm not sure. So again, we look at the relationship with all those functional measurements with the BV5 or the morphology. So we can see all those measurements significant correlated. All those are the functional measures. So what about the vascular change after the 1 year Trikafta? So we found out all the patients, the lung volume significantly increased. Well, it's kind of expect as they grow, right? And as well as for the total blood volume in the lungs. However, their blood volume in the smaller vessels does not significant change. That's what gave us the proportional BV5% as the ratio between the small blood in the smaller vessel over the total blood volume is significantly reduced. With all that data, we can have some conclusions. So the first we found that the blood volume in the small blood vessels they start declining as the normal lung function as well as early age, and this declining does not stop as the lung function get worse and as the patient's age. The decline in the small blood vessels also decrease their DLCO or diffusion as well as reduce their exercise performance. We hypothesis it's likely in early CF the pulmonary circulation contributes to the CF lung disease prior to the development of parenchymal lung disease. The mechanistic study about why and how they are losing the peripheral vessels will be present in the Saturday morning session, I think in the same room. Yeah. Now I would like to say thank you for the foundation to support the research and the great mentorship from Dr. Min and Dr. Bates and all the other people who helped along, and great experience collaborating with Dr. Schmil and Dr. Esper. Happy to take questions.
Thanks very much for this really interesting study. I guess I'll start with one question. Do the changes that you see with relation to lung function in your BV 5%, are they comparable to similar changes in other disease processes that affect the lungs? So for ILD or COPD, for example,
Yeah.
or is it specific to CF?
No, actually, yeah, probably I forgot to mention, because this matrix being widely used in the COPD group, so as show great sensitivity and great measurements in the COPD. So it's not like unique just for the
So
CF.
the destruction of the lung parenchyma from an underlying disease process impacts the small vessels.
Yes, yeah.
And then my second question about the pre and post Trikafta, what was the time window that you looked at? How did you give enough time for recovery of blood vessels to occur, for example, if that could potentially be delayed if there was improvement?
But for time-wise, my understanding is, should in theory the people who are eligible for the Trikafta treatment, they will start the treatment like around 4 weeks after they start, and then we image them like around 11 months plus minus 2,
Okay.
as the post.
So a fairly reasonable amount of time for structural regeneration to occur.
Okay.
Alan Ramirez from Louisville. It was very interesting. Quick question on the cardiopulmonary exercise testing. Did you see any other parameters that correlated with your blood volume? I'm particularly interested in the ventilatory equivalents for CO2, the VE over CO2, which might be a better reflection of pulmonary vascular disease.
Dr. Min, you want to answer this?
Yeah, so actually we are doing this analysis right now. So the only variable that we looked at for this presentation is the VO2 max.
Question.
Yeah, last question. So maybe this doesn't make sense, but I'm still going to say it. So is it possible that the loss in blood volume in the small vessels is reflective of inflammation and not remodeling of the lung? And is that why it's improving with, for example, Trikafta? And can you collect data on other therapies that in CF that would improve inflammatory state of the lung?
I guess, yeah, it's a good question. I think it's part of uncertainty. We don't know, because this, imaging-based algorithm is only can detect when, as telling by the image, there's a vessel there. It either can be, blocked by the mucus or just, as long as the limitation of image can't see it, we can't really tell, which factor is causing the, especially for the smaller ones.
Thanks for a nice talk. I'm sure you can guess what my question will be since I'm the endocrinologist here. Are these types of vascular biology changes seen in persons with diabetes? And is this something that you're looking at? And maybe it's going to be in the mechanism talk. I don't know.
I don't think we have. Yeah.
Okay. Yeah. Thank you.
I guess just to follow up on that, any potential interventions to prevent this from occurring other than protecting the lungs, is that going to come up in your mechanistic study as well? Sort of, are there specific targets that you could use to prevent vascular remodeling?
Yeah, it's a great question, and I think on Saturday the presentation will explain some of the mechanism that contributes to loss of small blood vessels, but restoring CFTR function is the mechanism. In fact, in the mechanistic study, I don't want to talk about the Saturday presentation, but restoring the CFTR function, which theoretically Trikafta should be doing this, in vitro actually is a good outcome. So it really prevents the loss of, it restores the angiogenesis that is seen with CFTR dysfunction.
Go ahead, Kathy.
This may be showing some lack of knowledge here, but did you look at echocardiograms at all to see, because some pulmonary hypertension also cause loss of the small blood vessels in the lungs, and so could the people with more severe disease also have pulmonary hypertension leading to some of the blood vessel changes?
No, there was echocardiography wasn't really part of the study protocol. However, the very good majority of the patients, well, I have to say, we started the study right before the FDA approved Trikafta, and when we started the study, the FDA announced the approval. So we actually had to look at subjects who were quite healthy. The 6 to 12, the very good majority of the children were 6 to 12, and they had normal lung function. Now, we did capture some patients with significant lung disease, and these were young adults, older adolescents and young adults. So echo wasn't part of this, but given that the very good majority had normal pulmonary function, it is unlikely that pulmonary hypertension is the reason behind this. Yeah, the ratio, correct. Yeah.
Well, thank you very much. Very interesting
Thank you.
presentation.
So the next speaker is Christina Mingora. I hope I pronounced that correctly. And she's going to talk to us about non-tuberculous mycobacterial infection as a barrier to lung transplantation in people with CF.
Good morning, everyone, and thank you so much for coming here today. I'm an adult pulmonologist from the Medical University of South Carolina, and I'm going to talk about NTM as a barrier to lung transplant in our patients with CF. I have no disclosures related to this presentation. So we know that NTM are often found in the sputum cultures of persons with CF. And when we look at registry data, we can capture the exact percentage of people that NTM is identified in. And historically, when we look back to 2010, when this measure was first introduced to the registry collection, we know it was about 10%. Through the years, starting in 2017 up to our most recent published data, we've seen some variation in the amount of individuals in whom NTM has been isolated, peaking in 2019, and then with decrease in more recent years, but still hovering around that 10% mark. So even though we're seeing a reduction, it is clearly still not an insignificant amount of our CF population. And I know all of us sitting in this room can name a few things that happened in 2020 and 2019 that may have affected our sputum culture measures. So I think there is some question there as well, is that impacted these numbers at all. So, how do we kind of talk about and think about NTM and CF? Because these are two kind of separate rare conditions, and how do we pair them together? So we know that NTM is significant in our CF population. And again, from our registry data, we know that Mycobacterium avium complex, or MAC, and Mycobacterium abscessus are the two most frequently isolated pathogens, which mirrors our general NTM population. In patients with CF, we know that this may be transiently or persistently present in the airway. So adding another variable if we're seeing single growth or kind of longitudinal growth in our patients with CF. But what we also know is that there are associations with adverse outcomes in the CF population, including reduction in lung function and accelerated rate of lung function decline, sort of highlighting why NTM are significant and very important for us to track, monitor, and screen for. We also know that there are additional concerns that NTM may play in decisions regarding future lung transplantation in all populations, but particularly in our population with CF. So looking to our current knowledge and what we have in our published transplant guidelines, we know that from the International Society of Heart and Lung Transplantation, Mycobacterium abscessus, particularly subspecies abscessus, is considered a high risk factor for lung transplantation. This is echoed, maybe not as specifically, but still present in the CF Foundation guidelines, who recommends consultation with local and geographically distant lung transplant centers for individuals with organisms that may pose risk for lung transplantation. And NTM in general, along with other kind of CF baddies, if we want to talk about for pathogens, Burkholderia and Scedosporium, are also listed in the CF Foundation guidance. Despite knowing this, we also have US CFF and ECFS guidelines that talk about management of non-tuberculous mycobacteria in individuals with cystic fibrosis. And this further goes on to say that the presence of NTM should not be an absolute contraindication to lung transplant. So, yes, we should be concerned about it, but it shouldn't be a be-all, end-all to making a transplant decision when it's there. So really just kind of highlighting these quotes from these guidelines that we have, saying that this isn't a straightforward problem. We have a lot of different things that we need to consider when we're moving forward with these complex decision-making. So going to the literature and trying to kind of also just put more context into this, we know that there has been work done by Kathy Ramos previously that looked at a survey sent to adult, affiliate, and pediatric CF programs. They looked at many factors that could potentially prevent referral for lung transplant, but focusing here specifically on what we have from a microbiologic standpoint, we again see that among things like Burkholderia, which we know are major concerns and have clear, issues than potential risk for transplant, we're also seeing NTM, and here again highlighting specifically Mycobacterium abscessus being a major concern that may prevent referral for lung transplantation. Additionally, though, previously published work showed that B. cepacia complex was really the only microbiologic predictor of non-referral. So again, we're just seeing people reporting different things when asked different ways. So kind of to frame how we got to doing this current work, looking at NTM as a barrier, we conducted a survey of lung transplant providers at CF centers across the United States. And when we asked them, kind of how do you view NTM in the transplant decision-making progress, this report indicated considerable concern for post-operative infection in individuals with history of NTM going lung transplantation. And this was not just for individuals with CF, but for individuals with other chronic lung diseases. Specific features that they particularly were concerned about were smear positivity in individuals who are continuing or persistently growing NTM, and different radiographic features, particularly looking at presence of cavitary disease, as well as any disease that was in close proximity to the pleura. And as above, there also were concern for significant postoperative infections in case there would be recurrence of the NTM or some sort of structural complication related to the lung transplantation procedure. So taking all that into account, looking into kind of our background, we designed our study with the specific objective to understand real-world practices in lung transplant referral, evaluation, and performance among persons with CF with NTM present in their respiratory cultures. In order to do this, we queried the CF Foundation patient registry and identified patients age 18 or older with available mycobacterial culture data. We used the years 2010 to 2019 because, again, 2010 was when NTM was introduced. And we went through 2019 because, again, we know a lot of stuff happened after that, and we didn't want to have too many confounders to add to the limitations of a registry analysis. Individuals who had culture positivity for Mycobacterium tuberculosis or anyone who had previously undergone a lung transplant was excluded. In doing this study, we conducted a primary analysis which looked at individuals who had % predicted lung function less than 30%. We selected this as our primary measure because this was the most stringent population that we could find, again, trying to eliminate any confounders that would go into this complex decision-making process. A secondary analysis looked at individuals with a % predicted lung function less than 40%, and individuals who had any additional markers of disease severity. This part, and we'll talk about it a little bit in the limitations, became slightly more hazy because we clearly have guidelines that tell us what these high-risk features are. But until, 2021, I believe, when, the advanced lung disease form was introduced into the patient registry, we didn't really capture as much of that. So here we were able to use some surrogate measures, but again, it's not exhaustive because we just don't have everything just yet in the years that we focused the study. So we looked here at use of continuous supplemental oxygen, history of massive hemoptysis, and history of pneumothorax. All of our patients that we looked at then were compared by NTM status. And by NTM status, we mean kind of focusing on what species of NTM were present in their cultures. For our statistical analysis plan, cohort characteristics were compared by inferential analyses, and covariate adjusted multi-level logistic regression models were used to assess lung transplant status by NTM culture status. In looking at our lung transplant status and our NTM culture status, this is how we stratified our patients. Again, this was using available data that was in the CF patient registry. For lung transplant status, we looked at referrals. We lumped evaluation and listing together because we figured that if patients were given the okay, the green light to undergo evaluation, there was at least reasonable hope or kind of thought process that they could potentially be listed. And then we put transplantation as its own variable. NTM culture status was looked at by any NTM species, and then again, looking at MAC and Mycobacterium abscessus individually, given again because those are the two most prevalently isolated, but also because we know that all of our previous kind of literature and guidelines are really focusing on this, kind of fear surrounding Mycobacterium abscessus specifically. Here's a truncated version of our kind of patient demographics, and we did collect more individual and disease state characteristics, as well as look at them not only in our group with lung function as defined here, but in the overall population. The full demographics can be seen on the poster 5, which I'll hang up after the session today. But what I included here were our characteristics that we found were statistically significant across all of these groups. So we found male sex, as well as F508 status, and education, and modulator use, which would not have included ETI at this point, but still would have previous modulator therapies available. Again, we did look at other things, socioeconomic status, enzyme status as a surrogate for pancreatic insufficiency, as well as CFRD status as well. Here we begin to look at our adjusted odds ratios. Here looking specifically just at our individuals with an FEV1 less than 30%. And again, these were adjusted for the significant demographic factors that we saw on the previous slide. As you can see, in terms of transplant referral, we were not really seeing very significant changes in terms of our patients not going to be referred, except somewhat perplexingly in the MAC population. I really honestly don't have an explanation for that. But we can see in terms of individuals who went on for evaluation listing and ultimately transplant, while we're looking at just the adjusted odds ratio, there is some reduction there. In the MAC population, those confidence intervals are not significant, but we really do see differences when we look again at our Mycobacterium abscessus population, where you're seeing more than 30% reduction in evaluation and transplantation in those individuals. Moving on to look at our secondary population of those with an FEV1 less than 40% with markers of disease severity, we're again seeing very similar findings here, where again, if you're looking at NTM overall, we're really not seeing significance there, but really where things start to stand out is looking into the Mycobacterium abscessus population, and again, how those patients are having significantly reduced likelihood of going on for evaluation, listing, and lung transplantation. Of course, as every study, there are limitations. So some of these are inherent to registry analyses. So quality and quantity of data, how many patients are being entered, how are we collecting it, and what's available. Because like I said, there is significant issues with trying to find these surrogate measures for advanced lung disease before you have the advanced lung disease form available to you. We also know that there is some heterogeneous data collection here, and there's possible sampling bias because we'll talk a little more about this in a slide or two, but when we're looking at screening in NTM, are we truly, as providers, being able to screen everyone as we're recommended to do, or are we only screening those more high-risk individuals who are more sick, who are having more sputum? So there are limitations to that. We also know that decisions to proceed with lung transplantation are complex. So additional patient-specific factors may result in reduced probability for listing and transplantation. So, other financial barriers, psychosocial factors, support, kind of all that stuff that goes into the lung transplant part. And then also the radiographic features that we talked about that our transplant providers indicated significant concern with. So what we found from, doing this study was that the presence of NTM in respiratory cultures does not appear to adversely affect the referral process. However, we do see that positive cultures associates with reduced likelihood for listing and ultimate performance of lung transplant. And this is, again, particularly notable for people with Mycobacterium abscessus in the respiratory cultures. So really, so what does this all mean then? What is the significance of doing this? And again, I think the things that really point out is that I think the role of NTM and CF continues to be somewhat unclear. We know there's cautions from the guidelines, but we also know that there's survey data from the past and from the present that are clearly saying that providers are concerned about it, that it's going to have some sort of potentially negative impact. We also know from this registry analysis, we're kind of all over the place, but do have that signal saying that Mycobacterium abscessus could potentially be an issue. And publications, if you just go to the literature, we see that there's a lot of variable outcomes. You can read things that say, it's okay, we can, NTM is not going to be related to poor outcomes, and then you read other ones and say, this is a case report of something really horrible that's happened. So again, there's going to be some reporting bias and all that. But really what we need to do and what we need to figure out moving forward is if we really do need to be afraid of NTM and we need to consider that there may be negative impacts of NTM in this transplant progress, then we really need to understand what we can do to improve upon this. So we need to talk about roles of enhanced screening and then consideration for early intervention, such as, we perform eradication protocols for individuals, children in particular, who have Pseudomonas. So real quick here as we wrap up, just kind of to put on the screening, this is a registry analysis that was published in 2020, and it was looking at screening practices for NTM. And what we're looking at are the % of patients at each CF center that were getting their NTM screening completed. So the red lines are, at the 50th percentile there. And we can see that, less than half of the centers were getting to that even 50% mark of performing appropriate screening. And we know that everybody is supposed to have at least one NTM culture per year. Looking down to 2014, which is the bottom panel, we see that improved over time, but still remains suboptimal, where there's a large proportion of individuals who are not undergoing NTM screening. Currently, taken from our most recent published registry data, we do see that these numbers are continuing to improve. So we do have most individuals who are producing sputum having NTM samples sent, but we also know that this continues to be a heterogeneous sample where it's not happening in everyone. and there is a lot of variability. So to wrap up here then, ongoing research needs, where we need to look at the assessment of post-transplant outcomes and complications in persons with CF who have history of NTM, who have undergone lung transplantation, again, to really see, are these fears, realized? And then, if again, we need to move on with enhanced screening processes, investigation of novel methods of NTM screening should be considered. And I know there are people who are doing work with that, specifically Jerry Nick and his team. So just really important stuff that needs to kind of be looked at moving forward. So I just want to thank Dr. Patrick Flume, who is my mentor and colleague, Andrea Bone, who is our statistician, and of course the registry team who helped us get this data. I'm happy to take any questions.
Thank you very much. So that was a very interesting talk. While we're waiting for questions from the audience, I wanted to start asking, the last point that you brought up, is there a lack of reliable data on outcomes in CF people who were transplanted with a positive NTM culture? Is that actually true, or is there published data on this that are reliable?
There's some published data, but I mean, there's a relative paucity of it. When you're going to do your search, you can get it down to, less than 50 articles that are going to be out there that are a published experience. And then the issue with that is it's not really systematically collected data. It's a lot of it based on case reports or single center studies. And a lot of that too, even when you look, it's hard to find CF specific data. I think it's not unreasonable to extrapolate some of the COPD and ILD and sarcoid and whatever, other sort of data you have, but the just real systematically completed evaluation of how CF patients do, not a lot out there.
Did you look at your population by geography? Were you able to see if there's any geographic differences? Because as you point out, there's variability in transplant centers' willingness to look at these patients, and you might have seen that in that study data set.
We did. I don't have that specific data like here though to show you.
Okay. And then,
but that was something that we looked at, and in our survey, which again I just don't remember off the top of my head, we did look kind of at the historical kind of distribution to see where which regions patients were coming from as well. So there is some regional variability, but I just don't have that specific number.
Thanks, Christina. That was really nice. This is such an important issue of non-referral for infection reasons. I think that the message somehow needs to get out that not all transplant centers are created equally. Their level of expertise and willingness to take risk with pathogens is highly variable. And now I think with the Mycobacterium, we have at least a phage as a potential for about half the patients that would potentially reduce their burden and help improve their post-transplant outcomes. The question I have for you is, how do we get the messaging out better that the CF providers should stop making decisions on who should be referred and who shouldn't be referred, and get the message out that people should refer regardless, and let the transplant center decide whether somebody is a reasonable candidate?
That's a great question. And I don't, honestly, just don't think I have a great answer to it. I mean, other than kind of talking, getting our publications out there and talking, together at places like this, it's really hard. I think that there probably are some patients who are more highly educated and more medically literate that kind of will be able to know where they can go. But again, it's so variable. I mean, and I know, like, I will go toe to toe with our transplant doctors and be like, that this is reasonable, this is not reasonable. And I know their limitations, and I know that we reach out to you often. So.
Yeah, there are these preconceived ideas in medicine that are they're just difficult to break down, right? People have ideas based on literature published 20 years ago, and therapy of NTM 20 years ago is very different than it is now. A lot of those case series are old and outdated. before we had agents like bedaquiline and things like bacteriophages. So it's really important that you're presenting this and highlighting the variability and the need for people to do better. And then we need outcome registries, right? The outcomes of transplant for CF with mycobacterial infections. It's just, we don't have a great registry mechanism other than the transplant consortium registry, which is now in its infancy and will take a long time before we have enough pre-transplant Mycobacterium abscessus patients to really know about outcome among different centers.
Yeah, and I think Liz Cromwell is working on trying to pair. Because obviously it can be done, right? Kathy's done work where she's paired things together, and I think Liz is working to try to pair the SRTR to the CF registry data. So there are opportunities. They're less than perfect, to some degree, but at least that would give us something, And then I think the other part of this that we need to work together to disseminate knowledge, with too is. Patients with CF are still going to need lung transplants, right? Like I gave a talk at CHEST on, modulator therapy and how it's impacting the future of CF. And, a transplant doctor came up and was like, well, I see like 2 patients a year now. And I'm like, oh, okay, that was this year. But, there's still a substantial population with advanced lung disease. So that's why I really think it's important to tackle these problems now. Because then when those individuals who got that little bit of a bump from ETI, you need a transplant 3, 4, 5 years, 10 years down the line, we have an answer for this. Because they're also going to have more risk of getting infections. So.
Well, thanks for your work. Keep up the messaging.
Thanks.
I just want to second what Dr. Paluski is saying, because I think the transplant decision surrounding NTM can be so individualized and varied, and we need more granular data, right? You can have someone who had a history of NTM isolation a couple times and cleared to someone who's smear positive, culture positive. And so how well is their disease controlled going into transplant? And when you have single centers or just retrospective, lumping them all into one category of NTM and then looking at outcomes, it really isn't kind of looking at it in a nuanced sort of way as to who does well with transplant and who doesn't. So we really need that registry. So looking forward to more data in the future.
And in what we have here, we just haven't gotten to completing it yet, but we're trying to look at some repeated measure analyses and time to analyses to see if, again, what you said, is it just a single positive culture that was 10 years ago, looked at differently than someone with persistently positive cultures? Are there temporal relationships from the last positive culture, first positive culture, to that kind of antecedent transplant decision moment? So we'll have that, and hopefully soon.
Even if just the last culture was positive versus negative might be predictive.
Yeah.
And it gets back to the point about treatment and clearance. I think many transplant centers, if the sputum is clear of NTM, are willing to proceed as opposed to somebody who's continuing to be smear positive. So.
And we have better treatment now.
Yeah. So that data may be readily available and will help to the points that Joe and Aaron made.
Yeah.
Terrific. Any other questions? Well, thanks very much.
Thank you.
All right. So our last speaker is Lauren Bartlett. She is senior research coordinator at the University of Washington, working with Kathy Ramos as well, and she's going to speak to us about preparing people with CF for lung transplant discussions and decisions. Thank you very much, Lauren.
Thank you for having me. Hi, everyone. I'm Lauren. I'm going to be talking about our qualitative outcomes from a pilot RCT that we did last year of a CF-specific educational website led by the fantastic Kathy Ramos. Okay. Oops. I have no relationships to disclose. So starting off with some background. So we know that transplant is a potentially life-saving treatment option for those with advanced CF, although many may die without receiving lung transplant due to decisional uncertainty. There are now recent CF Foundation guidelines that are trying to promote early education and clinical discussions to kind of prevent this from happening. So they're now recommending annual conversations for anyone with an FEV1 less than 50% of predicted. Although there are many barriers that exist that prevent these conversations from occurring in clinics, one of many are that there are very limited patient-facing resources on lung transplant that currently exist. And so our team kind of used that as an opportunity, and we developed Take on Transplant. So Take on Transplant is a web-based, up-to-date CF-specific, guidelines-based educational resource that we developed that contains information about lung transplant. And so I'm just going to kind of go through some of the main features of the website. We have what's called this My CF Stage, which is a personalized kind of assessment of someone's disease severity, and it provides personalized content on the website, and it gives everyone this lung transplant discussion urgency status based off of their responses to this personal assessment and CF guideline recommendations. There is a CF stories section, which includes personal narratives from patients and caregivers who share their transplant journeys. We also have a resource library section, which contains more of the didactic information about lung transplant, again, specific to CF. And we also have, lastly, we have the FAQ section, which contains common questions for patients about lung transplant. And it provides responses from patients and from providers as well. So we have done some fairly extensive testing on Take on Transplant over the years, and most recently we wrapped up the Lung Transplant Ready pilot RCT, where we compared Take on Transplant to UNOS.org as an attention control. UNOS is the publicly available website that contains all kinds of information about all kinds of transplants. And the aim of the pilot RCT was really to determine if there was effect on preparation for lung transplant discussions. We included adults with CF who had an FEV1 less than 50% of predicted and were pre-transplant. And one of our focuses was to oversample and include what we called the community of concern, which are individuals who are typically disadvantaged when it comes to lung transplant, who have worsened access and worsened post-transplant outcomes. So that included anyone who had Medicaid insurance, minority race, Hispanic ethnicity, and high school education or less. And so here just kind of describes what happened at each of the visits in the pilot RCT. So there were, the study lasted for a month. There were three sessions. All sessions occurred remotely, which was nice during the pandemic. At each of the sessions, there were survey assessments, and then there were also interviews that we did. Participants were randomized 1-to-1 to receiving either Take on Transplant or UNOS access first, and then after 2 weeks, we rolled them over, and everyone gained access to both of the websites. And so our qualitative analysis primarily focused on the interview that occurred at the 4-week session, primarily because everyone had access to both websites and could easily compare and contrast their experience using both of the websites. And so just to give you an idea of some of the questions that we asked during that week 4 interview here. So how did the content and the websites make you feel? Why might you choose to use Take on Transplant when you're healthier versus closer to needing a transplant? In what ways could Take on Transplant help someone who is getting ready to talk to their doctor about lung transplant? And how has it helped you feel more ready for these conversations? So getting into our methods for our qualitative analysis, we started by using those questions in our interview guide, and we developed a provisional code book based off of common kind of responses that came up. And then we refined that code book over time. We used Atlas TI software program, or qualitative analysis software program, to calculate Krippendorf's alpha for inter-rater reliability. And any time that we found that there was disagreement on codes between our group of coders, we discussed it as a team until we came to a consensus that we all agreed that certain codes were to be applied. And then once saturation was met and no new codes were coming up and no new themes were coming up, we didn't make any more changes to the code book. And we had a secondary analysis, again, kind of focusing on the impact of these lung transplant educational resources on that community of concern. So to describe who participated, we had a total of 50 participants in the pilot RCT who completed all study activities. We had we oversampled for that community of concern, and so you can see we had over 60% of people who were enrolled were in that community of concern, and we ended up coding 25 transcripts of the 50, and again we met saturation. So after the 25 transcripts, we didn't code any further. And so essentially once we concluded all of our analyses, we found that there were these two families that we classified our codes in. So the code family 1 included specifically information needs over time. So it focused on the lung transplant information, frequency and use of the lung transplant education over time. And code family 2, which was primarily focused on the influence of the use. So it identified emotional impact of the lung transplant information and how it may have motivated motivated their preparedness and decision-making certainty. And so kind of diving into the different codes that were included in each of these families, there were 5 codes per family that we came up with, and they're kind of described here. So early education was defined as the benefit or disadvantage of early exposure to lung transplant information. Evolution of use and future use was defined as how or why worsening disease severity may influence website use. Raising lung transplant awareness was defined as information that was useful or previously lacked. And unmet information needs was information that people sought out or questions that remained after the use of the tool. Relevance to self is defined as one's desire to understand how the content is or isn't relevant to themselves or the CF community. And so just to kind of highlight one of the many quotes that met this relevance to self. So one participant here said, "I've looked at stuff before and it was things that weren't relatable to me in my situation. So I thought it was cool because I could almost relate to everything I read and take on transplant. I was going, okay, I could see this." And then for code family 2, again, there were 5 codes that were identified, described here. So the call to action motivation code was defined as how the website may increase one's motivation to act. Lung transplant decision-making, certainty or uncertainty was defined as talking about certainty related to a lung transplant decision or uncertainty of the timing of a lung transplant discussion. Preparedness for lung transplant discussions with a provider was defined as description of how prepared or how comfortable one feels for a discussion with about transplant with a provider. In collaboration with allies in the discussion and decision-making process was engagement with other non-providers about transplant. So how and whether to use the Take on Transplant website or talk about transplant in general with others or loved ones. And then emotional impact, lastly here, was defined as description of feelings or mental health effects associated with the content or with just lung transplant in general. And so I have a quote here that met this emotional impact code. So one person says, take on transplant was more emotional than UNOS because of the CF stories, what they were going through before transplant, how they thought this could be my last breath, or they never thought the lungs were going to come in time, and the hardship of it all. And then another interesting thing that we found was that there was often a cause and effect type relationship between the two code families. And so to highlight one here, relevance to self and emotional impact kind of led to each other. So in this quote, you can kind of see that there's that relationship that exists. So this person says the emotional reaction to take on transplant was greater. It was more tailored to CF and what I would likely have to deal with personally in the future. At one point, when I first started going into my transplant evaluation, that's how I was feeling. I really related to that one CF story. It was empowering towards the end of it. It almost brings a tear to my eye just reading about it. Okay, so here we kind of describe, again, so our secondary analyses, we focused on trying to understand the impact and relevancy of the Take on Transplant website to participants in that community of concern. And specifically, we were looking at whether there were any financial concerns, social support concerns, any perceived burden on their caregivers, comfort discussing transplant, and experiences of provider bias. And so we had 17 transcripts that we analyzed in the secondary analyses. Those were the people who were in that community of concern. And what we found in the secondary analysis is there were some of these topics that were brought up at a greater frequency among the community of concern, and most significantly was the financial concerns. For the people in community of concern, there was a 59% versus 38% kind of frequency difference between the two categories. And then there were also some other kind of slightly increased frequency for social support concerns and burden on caregivers and comfort with discussing lung transplant with the providers. There were no participants mentioned any experiences with provider bias. So I will leave you with takeaways and some clinical implications to consider. So we found that people with CF have very dynamic information needs that evolve with their disease severity. Early access to disease-specific and personally relevant lung transplant information may increase someone's motivation to act, and it can allow for increased preparation and comfort with discussing lung transplant. And in our secondary analyses, we saw that there are increased barriers to lung transplant that exist for people within the community of concern, specifically the financial challenges that exist. And so it's really important for clinicians to take this into consideration, acknowledge it in order to promote more equitable access to lung transplant. And we did have limitations to our study, so it was a small sample size, and so results may not be generalizable, but we did have participants from multiple centers that were involved. And then because we did a study on discussing lung transplant, anyone who participated may have been more willing to discuss lung transplant than those that declined to participate. And then we like I mentioned, no one mentioned any experiences with provider bias in the interviews, and that's because we didn't explicitly ask about those experiences. I was the primary interviewer. I'm white female, and so people may have just not been more open to kind of sharing those experiences. So kind of moving forward, we still have some more extensive testing to do on Take on Transplant before it is publicly available. So we have a ongoing multi-center RCT, the Lung Transplant Ready CF2 study that's ongoing now at 9 centers across the U.S. And in the study, we will further explore experiences and perceptions of provider bias, kind of more specifically. And I will end with our many, many thank yous to anyone who participated in the study and shared their very, very valuable perspectives with me. Many people were very, very vulnerable in those conversations. So, and we have our primary project team who's been working with us for quite some time, and the many collaborators who helped with the pilot RCT. Thank you.
Thanks very much, Lauren. While people are coming up with questions, it seemed like you learned that patients have evolving needs through the course of their interactions with your information or the information they need to prepare for transplant. And you tailor the information based on a self-assessment survey at the beginning, which is mostly about where you are in relation to transplant, I think. Have you thought about tailoring information in sequential visits to the site based on their evolving needs? So maybe having a follow-up questionnaire, for example, based on your initial pass at the site that says next time you come back, you'll get a different set of information that's tailored to the needs that you identified in the study.
Yeah, good question. So in the Take on Transplant website, people are able to kind of go in and re-enter their information in the MyCF stage personal assessment. And so if there are changes in their health status, they can kind of go in and make some updates to their questions that we ask. And so they can continue to get updates on their recommendations or that disease or discussion, lung transplant discussion urgency status. Mm-hmm.
And then theoretically, you could learn how people use the site and use that information to tailor the information they get going forward. So if you're tracking what people read and how they click.
Yes, we are doing that.
Okay.
Yes. We have a whole team of developers who are helping with kind of the algorithm, and it's really interesting.
And then I guess I'm going to dominate the questions then. So wearing my UNOS hat, did you learn things about the difference between the way you've presented information and the way that the OPTN website presents information that would be beneficial as they provide information not just to lung transplant candidates, but to all transplant candidates? And is there an open dialogue, or could there be an open dialogue?
Yeah, so the overwhelming summary as the patient experience in using the UNOS website is it's overwhelming. It's people don't like the experience of going to the UNOS website, and really what seems like the biggest feature of the Take on Transplant website that the UNOS website doesn't have is the CF stories. People really like hearing experiences from people who are like them, and that really connects people to our website.
I'm gonna add just a tiny bit. You did such a fantastic job. Really, honestly, you did a great job, and integral to all the research, doing all the interviews, and you've got a lot of insight from that. For the UNOS, I chuckled because one of the quotes that we use as an example is UNOS is chaos. That's because it's hard for people to know where to go for exactly what they're looking for when they are a person with CF looking for lung transplant information. It's buried really deeply, but I will say people learned from UNOS. This was an active intervention, and we called it attention control, but it was not a control. People learned a lot from the UNOS website, and we recommended in the pilot RCT that people spend 2 hours with the website to which they were assigned, and people did it. They listened, they went to UNOS for 2 hours, and they came out with more lung transplant knowledge and feeling more prepared. So not as prepared as if they went to Take on Transplant, thankfully, but it was not a total placebo on that website.
So I would encourage you, if you haven't, Kathy, to think about providing that feedback to the OPTN contractor. You may be aware that contract is going to switch sometime in the next 6 to 12 months. UNOS may retain some part of the contract, they may not. but there'll be an opportunity in that evolution to provide input on how the OPTN, which is what the contract that UNOS holds, how that has its public-facing, patient-facing aspects going forward. And I think the information that you guys have gathered will be really valuable for the OPTN as they develop patient-facing information in the future.
Yeah, no, that's good point. And if you give me the contact info, I'm happy to connect.
That's a bit blurry right now, but we can talk afterwards. Any other questions? Well, I want to thank all of our speakers for being on time, for having concise and informative presentations, and I thank the audience for the questions. And I hope everybody has a great rest of the CF conference.